Hello and welcome. In this video, we are going to talk about acute fatty liver of pregnancy. Obstetricians and physicians need to have awareness of this disease, which is specific for pregnancy and is a very serious disease with a poor prognosis. It's important to know that liver failure may present apart from acute fatty liver of pregnancy. And these are two distinct terminologies. Liver failure can occur for different reasons, as it is a generic term used to describe the condition where the liver is not able to function. Acute liver disease of pregnancy is a disease which is specific to pregnancy, and it will not present in non-pregnant women or in men. Causes of liver failure include acute fatty liver of pregnancy, HELP syndrome, preeclampsia or eclampsia, viral hepatitis, biliary obstruction, drug-induced liver injury, or acute liver diseases such as acute cholecystitis or acute pancreatitis. Early diagnosis and prompt treatment are crucial for managing all these conditions and ensuring the health of both the mother and the baby if the failure is occurring during pregnancy. It is important to remember the difference between the terminology of acute fatty liver of pregnancy and non-alcoholic fatty liver disease. These are not the same. In both these conditions, there is fat accumulation in the liver, resulting in liver failure. However, acute fatty liver of pregnancy is a pregnancy-specific acute and potentially life-threatening condition which requires immediate medical intervention. Non-alcoholic fatty liver disease is a chronic condition. It is associated with lifestyle factors and is a metabolic syndrome. It can affect men and women and is not specific to pregnancy. And now to review our main topic of acute fatty liver of pregnancy. This is a rare condition, but it is a very serious condition. In this, fat will build up in the liver and will actually cause the liver to fail. It usually occurs in the second half of pregnancy, typically around 36 weeks. The differential diagnosis of acute fatty liver of pregnancy includes fulminant viral hepatitis, drug-induced hepatic toxicity, idiopathic cholestasis of pregnancy, adult onset Rye syndrome, which is a rare but serious condition that causes swelling in the liver and in the brain and can occur at any age, and usually after a viral infection, most commonly the flu or chickenpox. Another differential diagnosis is hemolysis and elevated liver enzymes and low platelets, or the HELP syndrome. Drugs can induce liver failure, and this is important information, especially in countries where patients will self-medicate and over-the-counter drugs may not be regulated. The most common drugs which can cause liver failure include analgesics, antibiotics, statins, and herbal supplements. There are no geographic or racial predisposition for acute fatty liver of pregnancy, and risk factors include older maternal age, primary parity or multiple gestation, preeclampsia, having a male fetus in utero, being underweight, and a past history of acute fatty liver of pregnancy. Other risk factors include a genetic mutation that affects their mitochondrial fatty acid oxidation pathway, and if the mother is carrying a fetus with a long chain 3-hydroxy acyl coenzyme A dehydrogenase or LCHAD deficiency. So the long chain 3-hydroxy acyl coenzyme dehydrogenase or LCHAD enzyme, which is important for breaking down certain fats in the liver, if this enzyme does not work properly, then these fats will build up in the liver. Research shows that if the mother is carrying a baby and the baby has a problem breaking down fatty acids, then they are much more likely to develop liver disease like acute fatty liver of pregnancy or HELP syndrome. However, not all mothers with these babies get liver disease. And some scientists think that mothers who have one normal and one mutated LCHAD gene are at risk because they can't handle the extra fatty acids from the fetus. So as these extra fatty acids enter the maternal circulation from the fetal circulation, their fats will build up in the liver of the mother, causing it to stop working properly and eventually leading to liver failure. The symptoms of acute fatty liver of pregnancy will develop over several days or it may take several weeks, and these include non-specific symptoms such as nausea, vomiting, loss of appetite, fatigue, abdominal swelling, and yellowing of the skin and the eyes. The abdominal swelling may be associated with ascites. Additional symptoms will include increased thirst and frequent urination due to transient diabetes insipidus. About half of the patients may experience acute kidney failure and liver-related brain dysfunction or hepatic encephalopathy. Around 50% also show signs of preeclampsia, such as high blood pressure, protein in the urine, and swelling all over the body. Hypoglycemia is a very critical and important symptom of liver failure. It happens because the liver plays a crucial role in maintaining blood sugar, and in failure, the liver's ability to store and to release glucose is impaired, and this can lead to low blood sugar levels. Hypoglycemia in the context of liver failure can be a serious and potentially life-threatening condition requiring prompt recognition and treatment. Symptoms of hypoglycemia can include confusion, weakness, sweating, shakiness, in severe cases seizures or loss of consciousness. The management will involve the administration of glucose and addressing the underlying liver disease. In severe cases of liver failure, this might even include consideration for liver transplantation. Diagnosis of acute fatty liver of pregnancy can be made by looking at the patient's symptoms and the lab test results. The significant symptoms are related to hypoglycemia and liver encephalopathy. The levels of liver enzymes in the blood are moderately high. The bilirubin levels are usually below 5 milligrams per deciliter, but higher in serious cases of acute fatty liver. And other common problems include a high white cell count, low blood sugar, high ammonia levels, low platelet count, high neutrophil count, blood clotting issues, and kidney problems. A CT scan will show widespread low-density signals in the liver and ascites, but liver ultrasound often appears normal due to microvesicular fat deposits. A liver biopsy can provide a definitive diagnosis by revealing microvesicular steatosis, which means fat droplets around a centrally placed nucleus. Liver biopsies are rarely done because of the quick need for making a diagnosis and managing the patient, and because of the risk of coagulation disorder, further compromising the patient's condition. The famous Swansea criteria, which are used for diagnosis of acute fatty liver of pregnancy, are a substitute for the liver biopsy, and these Swansea criteria are based on a bunch of symptoms of lab results and laboratory findings and of a biopsy, which is the microvesicular steatosis on liver biopsy. So the authors actually propose that at least 6 criteria should be present for a diagnosis to be made, but other authors have suggested that at least 7 or even more than 7 criteria should be satisfied to make a diagnosis of liver failure. As far as treatment is concerned, the American College of Gastroenterology guidelines suggest that women who are diagnosed to have acute fatty liver of pregnancy should be delivered promptly, and expectant management is not appropriate. All women with acute fatty liver of pregnancy and their children should undergo molecular testing for LCHAD. The offspring of women affected by acute fatty liver of pregnancy should be monitored carefully for the manifestation of LCHAD, including hypokinetic hypoglycemia and fatty liver. Any patient with a possible diagnosis of acute fatty liver should be immediately admitted, as the disease is characterized by progressive and sudden deterioration. There should be involvement of the multidisciplinary team, and continuous fetal monitoring should be initiated. Lab tests should be drawn immediately, and supportive measures should be instituted to stabilize the mother. These include glucose infusion, blood products as needed, with careful attention paid to the patient's fluid status. The primary treatment is prompt delivery of the fetus, which stops the overload of fatty acids from the fetus onto the mother's liver, as well as supportive measures to stabilize the mother. Recovery before delivery of the baby has never been reported. Induction of labor is a viable option if rapid vaginal delivery is expected, as it can hasten resolution of the disease secondary to early delivery. A cesarean delivery may increase the risk of maternal morbidity and the need for blood products, and the route of anesthesia should also be discussed between the obstetric and anesthesia teams. Some patients may require general anesthesia due to coagulopathy and concern for hematoma formation with regional anesthesia. Having said that, most patients with acute fatty liver of pregnancy will have cesarean section because of the urgent need for delivery if the cervix is not favorable. Most patients will start to improve within 48 to 72 hours after delivery and demonstrate an improvement in their levels of aminotransferases. Those women with evidence of coagulopathy, encephalopathy, or hypoglycemia on admission often require continued intensive care level monitoring. They may require transfer to centers capable of liver transplantation. Liver function usually normalizes within 1 week, but may be delayed for months. Complete recovery is generally anticipated. As far as the prognosis is concerned, the maternal mortality has been as high as 70%, but with good management and good resources, this may decrease to 7 to 18%. Maternal complications include postpartum hemorrhage, renal failure, hypoglycemia, disseminated intravascular coagulation, pancreatitis, and pulmonary edema. The perinatal mortality used to be as high as 85%, but again, with better management and resources for better management, the rates are between 9 and 23%. About 75% of the deliveries are preterm, iatrogenically, because immediate delivery is necessary, with the average delivery happening at 34 weeks or even earlier. If possible, all babies born to mothers with acute fatty liver should be tested for defects in fatty acid oxidation, because early detection and treatment can reduce death and illness. Recurrence of acute fatty liver of pregnancy is rare, but can occur often in carriers of LCHAD mutations. Affected patients should be closely monitored by maternal fetal medicine specialists. The European Association for the Study of Liver Diseases have published some recommendations and guidelines about evidence for plasma exchange. They have reported some outcomes of women with acute fatty liver which has been treated by plasma exchange. There was no significant difference in mortality rate between the two groups, but the plasma exchange group had shorter intervals of hepatic function recovery, of stay in the intensive care unit, and of overall hospital stay. The sooner after the diagnosis of the disease the patient received plasma exchange, the faster the recovery time. There are some adverse reactions associated with giving plasma exchange, and these include pulmonary edema, hypocalcemia, metabolic alkalosis, hypernatremia, itching, and lower limb convulsions and fever. In all studies, these were reported as mild and all improved after treatment. Limited evidence is available on plasma perfusion or continuous hemofiltration in patients who are further complicated by acute kidney injury or multi-organ failure. The European Association guidelines for the use of N-acetylcysteine shows that there is no data to support the use of this drug for the treatment of acute fatty liver of pregnancy, but benefits have been demonstrated for other causes of non-paracetamol-induced acute liver failure. There are no known risk factors or risks of using this drug in pregnancy. A small proportion of women will progress to acute liver failure despite delivery of the fetus. In such cases, a liver transplant will be required. The European Association of the Study of Liver Diseases does give some evidence in this matter. However, this evidence is very limited. We compared the women who required transplant for acetaminophen poisoning or other causes with women who have acute fatty liver of pregnancy. And in terms of outcomes, the acute fatty liver group has the longest number of days from the liver transplant to hospital discharge and a similar 5-year survival. With this, we come to the end of our presentation. And for those of you who may be very interested in this topic and would like to do further research, some important references are mentioned here, which you can use for your study purpose. So with this, I would like to thank you for listening to this video. Please subscribe, press the like button, share with colleagues and friends, send your comments, and press the bell icon for receiving notifications about future videos. Thank you and goodbye.